One of the most frustrating experiences for patients is being told your MRI is normal, and yet the pain is very real. Severe, cyclical, sometimes debilitating. This is where peritoneal endometriosis enters the conversation. I'm Dr. Abhishek Mangeshikar, and today I want to explain what peritoneal endometriosis is, why it's often called the invisible form of the disease, why it can cause significant pain despite minimal imaging findings, and how it differs biologically from deeper infiltrating disease. Because invisible does not mean insignificant. The peritoneum is a thin, transparent membrane that lines the inside of the abdomen and covers the pelvic organs. It is delicate, highly innervated, and very sensitive. Peritoneal endometriosis refers to lesions that grow superficially on this lining rather than burrowing deeply into organs like the bowel, bladder, or parametrium. These lesions can appear as tiny, clear vesicles, red inflammatory spots, white fibrotic patches, or subtle discolorations. Some are almost microscopic. They do not form large masses, they often do not distort the anatomy, and because of that, they are frequently missed on ultrasound and MRI. This is why imaging can look normal. Here is where we need to separate stage from suffering. Pain intensity does not always correlate with disease volume. Peritoneal lesions sit on a membrane that contains abundant nerve endings. When these implants become inflamed during hormonal cycles, they release inflammatory mediators, substances like prostaglandins and cytokines, which irritate local nerve fibers. Even a small inflammatory lesion can generate disproportionate pain signals. Additionally, over time, repeated inflammatory cycles can lead to peripheral nerve sensitization. That means the nerves themselves become more reactive. Eventually, even mild stimuli may produce exaggerated pain responses. This explains why some women with stage 1 disease can have severe pain, while others with stage 4 disease may have a little mild discomfort. Biology is more complex than staging. Peritoneal endometriosis is difficult to detect for several reasons. First, the lesions are often flat and small. Imaging techniques are better at detecting structural distortion, thickened bowel walls, large nodules, ovarian cysts, rather than subtle surface inflammation. Second, unless imaging is specifically performed with high suspicion and protocol optimization, superficial implants are easily overlooked. Third, even during surgery, peritoneal disease can be underestimated if the surgeon is not actively searching for atypical appearances. Some lesions are translucent and require careful inspection under close magnification. This is why peritoneal endometriosis is sometimes dismissed, not because it isn't real, but because it doesn't behave dramatically on scans. The term mild can be misleading. From a structural standpoint, peritoneal disease does not invade organs deeply. It does not narrow the bowel or compress the ureter. That makes it less dangerous in terms of organ compromise. But from a pain perspective, it can be highly disruptive. Another important point is that peritoneal disease may represent an early biological stage of endometriosis in some patients. In others, it may remain superficial and never progress to deep endometriosis. We do not fully understand why some lesions become invasive and fibrotic while others remain superficial. This is where evolving research into inflammation, immune dysfunction, and epigenetic changes becomes important. Treatment depends largely on symptom burden and life impact. Hormonal suppression can reduce inflammatory cycling and may reduce symptoms. However, suppression does not remove lesions, it reduces activity. Excision surgery, when performed carefully, removes the visible peritoneal implants. In many patients, this leads to significant symptom improvement, especially when inflammatory lesions are fully excised. The key is precision. Overly aggressive stripping of peritoneum without clear targets can increase adhesions. Under-treatment leaves inflammatory tissue behind. This is not a disease where burning a few spots casually is adequate. Thorough inspection and disciplined excision matter. There is another layer we must discuss honestly. In some patients, pain persists even after complete excision of peritoneal disease. That does not automatically mean the surgery failed. Chronic inflammatory pain can, over time, alter how the central nervous system processes signals. This is called central sensitization. In simple terms, the pain system becomes amplified. When that happens, treatment requires a broader strategy, including pelvic floor physiotherapy, pain modulation techniques, and sometimes neuromodulatory medications. This does not invalidate the disease, it explains the complexity of pain biology. Peritoneal endometriosis challenges the assumptions that big disease equals big pain. It reminds us that inflammation, nerve interaction, and immune signaling are just as important as anatomical distortion. A normal MRI does not exclude endometriosis, minimal disease does not equal minimal suffering, and superficial does not mean imaginary. Peritoneal disease may not always appear dramatically on scans. It may not invade organs deeply, but it can profoundly affect quality of life. Understanding this form of the disease requires us to move beyond staging labels and into biology. If this helped clarify why pain and imaging don't always match, share this with someone who has been told their scan is normal but the pain is dismissed. And if you value structured, science-based conversations about endometriosis, make sure to like, share, and subscribe so that we can continue raising awareness in a meaningful way.